good evening. Myself, Dr. M.S. Ahire. I am presenting behalf of this case from Dr. Gaurav Verma, sir. The unusual complication of in TAVR with the bicuspid valve, small annulus and heavy calcium with the LBBB. The patient history is 77-year-old female, known case of diabetic hypertension since 5 years. Medical complaint is exertional dyspnea since 1 month, and known case of CRF with creatinine 2.5. ECG is suggestive of complete LBBB. 2D echo, Vmax is 4.8, peak gradient 92, mean gradient 45, LVF is 60%. Advice for SAVR with versus TAVR. Coronary angiography suggestive of mild LM plaque. So with the 77 years old, we decide to go for the TAVR. Here is a CT assessment. The aortic annulus perimeter is 60.2 millimeter and area is 274.2, and ascending aorta is 35 millimeter, and sinus Valsalva junction is 24.6. It is roomy, and LM height is 11.8 millimeter. RCA height is 12.4, which is quite good. And it is also suggestive of some calcification here. Angle is the co-penal angle is the 54 degree, little bit horizontal. So according to the CT assessment, we choose the wall, which is the almost 14.7% oversize. Because the patient financial constriction, and we are not able to choose the self-expanding wall in this case, because this case is ideal for the self-expanding wall because of the high calcium small annulus. This is the vascular anatomy, where is the adequate diameter of the peripheral vessels. The risk factor here is the elderly with CKD patient. Baseline is the LBBB. Maybe need for the permanent pacemaker. And challenging for is a small annulus, bicuspid aortic valve, a little bit horizontal aorta, and heavy calcium and torticity. The strategy of the procedure is the transfemoral right side, and bicuspid type 0 aortic wall, moderate aortic wall calcification is present. Recommended by my wall 20 millimeter size based on the annulus sizing. Right femoral access for the main site. Closure with the ProGlide vascular closure device. So we started putting the temporary pacemaker because of some anatomy, little bit difficult, but finally we put successfully. You can appreciate the calcium here. It is very heavily calcified wall. Angiogram is done, and it is suggestive of highly calcified and horizontal, little bit horizontal position of the annulus. Then we crossed the ST wire over the AL1 catheter and successfully crossed, and after that dilated with the 18 by 20 millimeter balloon. As the immediately wall position is done, there is a patient goes into the cardiac arrest, and while the wall is crossed the annulus, so we immediately wall position and deployed. And after deployment of the wall, we started a continuous CPR. There is a recurrent VF, and repeated cardioversion were continually done for the 10 minutes before the spontaneous rhythm is got restored. And just look in the echo, there is a pericardial tamponade. So we inserted the sheath and inserted the pictal catheter and drain out the pericardial effusion fluid, And what will be the possible complication maybe here, as the patient has bicuspid aortic wall with a heavily calcification, and it is a balloon after the balloon expandation we deployed the wall, we thought maybe it is the annular rupture, and so we immediately take to the cardiac OT, and what we find that there is the RA appendage perforations. So surgeon immediately closed that. The surgeon is just switched the knot here, and
were you wanting us to hear some expletives? I mean,
yes, sir, there is some expletives.
Was there going to be some choicest Punjabi phrases going to be used?
And in the OT findings, the RA appendage is perforations, no annular leak, patient maintained on ventilation over the night, extubated on the next morning, discharged after the 5 days. Learning points is gentle handling, RA-RV, rashness and overconfidence, and done the perforation, and it can be lethal.
So the most difficult procedure in interventional cardiology is a temporary pacemaker, according to me. I mean, because you need to do that very well, and especially in the middle of the night, and if you have a patient who is syncoping, and you're trying to get a pacing lead across, and even a very senior operator can be left with egg on his face if he can't do that correctly, and if in haste you push it. For a moment, I thought your pacing was going to have gone transeptal through a PFO and come and pacing the LV. I mean, that was when the fluoroscopy was being seen, but evidently you punctured the RA appendage, and therefore a temporary lead, this is one of the advantages of taking a balloon-tipped catheter, so that you don't have these things happening.
I have a question. Do you, so after you obviously in the cath lab you put pericardial drainage, right? So was it continuing to bleed? Did you reverse heparin? Because, I think it could have stopped maybe spontaneously just by reverting.
But I think because they'd used a balloon expandable valve when there was calcium, so they had a fear that they had caused, but an annular disruption would have been more catastrophic.
But
So
annular disruption...
This is not an annular disruption.
I mean, annular rupture, the patient is anyway dead, with or without the stenotomy.
Yeah,
So that patient doesn't go to the OT,
you didn't have time to take a shoot, aortic root shoot?
Yes, sir, we done the shoot, but there is not suggestion of annular leak. Like still there is a continuously blood flowing freely, so we don't have that much time. So we immediately shifted to the OT.
The pacing lead is a culprit many times. So nowadays they pace on Safari. Many places they pace on Safari.
But also keeping a balloon tipped.
Yeah, balloon tip is also okay.
Very simple.
So only
simple.
And in my lab, this patient. So if the patient is in control, then we wait, and then we can see if we can solve the problem. Not under control. It's still flowing like you're saying. He does not have time to go to the OT. He's opened on that table. So we do stenotomy there, not...
Yeah, so a simple solution many years ago, which Rehan had reported, and it was, I think, published finally in CAT-CVI, was that especially when you're doing balloon mitals and you have a stitching phenomena, when you go through the bare area and the intraatrial septum, if you inject a little bit of glue, it goes and seals just the point of perforation. So if you're to do it transpericardial.
What's that glue? I like the idea.
Yeah,
I've never done it.
It's a smart idea.
That's what I do with my bike. I put stuff into the tire and it seals the hole. Is this the same thing?
So rather smart. But
so what kind of glue is that? Bioglue, like they have
the same biological glue.
Okay.
So you put it into the pericardial space, and it localizes to the point of perforation. So especially, so this will be noted, especially when we do balloon mitals. So there are adequate references. Vijit Rehan is the first author, so you can check it. It is a CAT-CVI publication about 15 years ago.
Because that's a good idea for example, for left atrial appendage. You can have a leak.
Yes, you can.
Brilliant, fantastic presentation.